move the needle out and in, because as I told you before, the cutting part of the needle is just the tip. And then before exiting, again releasing the proteolytic solution. Of course, it's possible to use after the procedure to use a Steri-Strip to close the hole. And depending on the patient that you are treating, the use or not of the local anesthesia, but it's not something mandatory, let me say. So I have patient where I can perform the procedure without the use of local anesthesia without any problem, and the patient after the procedure asks me if we are starting the procedure, but we have already finished the procedure, and some other patient where the local anesthesia is recommendable. Okay, you have some other questions? If not, I have finished.
We will have a live demonstration on Renuva for the hand by Dr. Firas.
هتمسكها بايدك؟ خلاص no problem. Okay. This is the product. نبدأ. Testing, testing, testing. نفرجيهم هيدي العلبة. Okay. Yes. Exactly. صح. نحن we're gonna do this. Yes. هذا ال 1 Okay, نبدأ. We test, we start. Okay, so what we're doing today is demonstration of Renuva injection to the dorsum of the hands. You know, this lady, you know, testing. Can you hear me? Hello? Testing. Hello. Testing. You can. Okay, you can hear us. All right, so basically what we're doing, this is the Renuva. There's two kinds. What we are getting here in the UAE is hydrated, so it's already pre-mixed, and it's the 1.5 cc syringe. It's already pre-mixed, but because we want to distribute it and the skin is very thin, we will like to dilute it to 1 cc, so we'll inject 2.5 on each side. It's 1.5 of the Renuva extracellular matrix, hydrated or diluted to 2.5. So it comes in as a pouch. We will open it. We don't have to freeze it. Okay. And, okay. So this is how it comes. This is the extracellular matrix with no fat cells in it. We will inject, it's the honeycomb idea that we will inject in the dorsum of the hand, and we will allow the body to populate this with the fat cells, and also allow blood vessels to grow into the area. So this is 1 cc of saline. It comes in with the connector. And what we will be doing is just homogenize it a little bit more. Okay, so we will have a total of 2.5 cc's. As we mentioned, it will be, go ahead and connect the cannula. So we want to inject the dorsum of the hand. Emla cream was applied, and we injected here just 0.5 cc's of Xylo without adrenaline, so that the puncture point or the entry point is comfortable for this patient. All right, so entry point, we'll try to make it so it should be painless, and we will prime the cannula. Okay, it's primed, and we will go in. It's a long cannula, so here we go. So we are under the skin. We can tent the skin away from the blood vessels, and from this entry point I will reach all this area right here, and I know I have 2.5 cc's, so I will gauge it the way it would be, and then we will massage after the first point. So we try not to double place any product in this area, you know, and try not to puncture the thin veins. I'm going to do half the hand, and we will see half done, half not done, and then we will go and we will show one arm done, one arm not done. It should be painless if we are on the right plane. If we are sticking to an area where it is fibrotic, we go back and we try to recanalize in a nice way. So, okay, so we are at 1.5, and I'll go back here in this middle area, and I will inject to this one. This is just regular fusidine, or if you have Vaseline or anything, and we spread it, we spread it, we spread it, and we'll bring it back this way and this way. So if you can see, this area we injected compared to this area that's not injected. So the skin is a little less transparent. This is only the matrix. There's no fat cells here. So you can compare them in 2 weeks, 1 month, 3 months, and even 6 months and 1 year, and you'll see the improvement. We'll go to another entry point. You can have one entry point in the middle, but I'd rather use 2 entry points to have more homogeneous distribution. And we go here. So 22 gauge cannula, and we are in. Small aliquots placed. Painless technique. We really don't need the local anesthesia at the entry point, but because the needle, the cannula is 22, it's a little bit big, and our patient has waited patiently since 7 o'clock, so we made it painless for her. Here we go. And one more here, and this way. So this is one hand done. We massage, and we instruct her to massage it for the next few days. Minimum redness, should be no pain. Okay, so let's take a look at this hand compared to the other hand. So basically, we can see how transparent is the skin. Now it is a little bit less, but this is the matrix with no fat cells. What we expect is, with time, it will continue to be smooth, nothing lumpy, bumpy like with fillers, and nothing bumpy or just bulging here like when we inject fat cells. And then basically when we inject fat cells here and the recipient is there's no tissue or muscles or even adipose tissue, the fat cells will die and we remain with the extracellular matrix, and then it gets repopulated. This is cutting through the chase, putting only the extracellular matrix, and then allow the body to absorb. So we're going to go to the other hand. I'll come to this side, switch with the cameraman. Okay, homogenized already? No, we will homogenize. So 1.5 cc comes sterile pouch, hydrated already. 1 cc of saline, you can put 1.5, but for us, okay, and then we will homogenize very gently to soften it, to make it easier for injection also. Okay, good. Good. So also 2.5, put it on the cannula. Very sensitive skin, so even from the injection side, she got a little bit of bruising, but we can see with the cannula here, should be no bruising, nothing whatsoever. Needle, entry point. Okay. And the same, just get in the right plane, painless, and try to avoid puncturing any vein. I always inject in a retrograde fashion, got used to this, and it should be no issue here. We should not push and inject, so go all the way in, and this is a long cannula. We can get even into the fingers if we want, and we're injecting and injecting. So if you want one injection point, you can come all the way here, all the way here. So I'm demonstrating in one hand 2 injection points, in the other hand 1 injection point if we get to. But I'd rather not come across the veins like this, so I will go back and enter from the other side, and I'll be staying parallel to the veins, decreasing the risk of trying to minimize the entry point, but increase the risk of possible puncturing a vein and causing a small bruising and hematoma that will stick to the hand for the next week or so. Okay, so parallel to the veins, superficial, we can see the cannula all the way, and we can inject it as superficial as we want, it's not a problem. And voila. Okay, so it's a very quick easy procedure. It's not a filler today, so I'm not going to expect the patient to tell me, doctor, you know, what you injected, I don't see any effect. This is a process that you have to have faith in the product, and with time, they will keep coming back. So as I said, this hand was injected almost 14 months ago. You could imagine if that was not done. We had the picture before, and you know, she can be outside for if somebody has to ask her question to tell you how much improvement she felt without the stigma of injection of fat in the dorsum of the hand that we see some people walking into our office wearing a beautiful watch with a big lump of fat over their hands. Thank you very much.
Any questions?
Thank you, Dr. Firas.
All right, I'll be out. If anybody wants to ask questions during dinner, we'll be available for any questions. Thank you so much.
He didn't.
Oh, there's another question.
Yeah.
Here we go.
Thank you.
Yes.
I wanted to thank you for the presentation, previous one. It's amazing and very scientific. And actually, I had the chance to try this product. I treat the patient suffering from lipoatrophy after facial nerve paralysis. And I noticed after a few months that the skin I treated the side, it's more beautiful than the other side. So I think this is very promising product. And my question is, because it's extracellular matrix, do you think or there is any studies on the scar healing in better way, or hypertrophic scar we can improve, or there is any way to help in wound healing in beautiful skin, not scarring? There is any research about that?
I don't know exactly how to answer that question, because for hypertrophic scarring, usually we want them to be less, but we've showed evidence of depressed scars in the abdomen and in the breast, where putting the extracellular matrix and inviting the fat cells to populate it in a nice way, not just filling it, was very good. It will be a very nice study to do, like when we're doing an abdominal scar, maybe after the healing has taken place, so that, you know, or even for C-section ladies, you know, they always have a depressed scars. To put that, you know, a month or so later after it, it could be a very interesting study to be done, but I'm not aware of one that's done. But it's a very nice and intelligent question indeed.
I think the difference is now we are working on volumization. But if I don't know if there is any researches looked for the cellular interaction, what is happening between the growth factor and this extracellular matrix, so we can use it even in less concentration. I don't know if there is, I will go to search about it, because I read about this with the SVF.
Yes.
Yeah, so maybe in the future, if this interaction, we can work on it before the complete remolding stage of the wound healing, maybe we will have a good result in the future.
It will be a very interesting study indeed, actually.
Thank you.
And if you find something, please let me know.
Sure, sure. Thank you.
Thank you.
Okay.
Thank you so much. So the next will be a demonstration for endolift with Dr. Basil, I believe. Huh? Dr. Roberto, I'm sorry. So Dr. Roberto will do endolift on the next patient. Waiting for him to come this way. Dr. Roberto, please.